So my name is Regueiro. I'm from Barcelona, and I will present this talk that is about changing the pacing paradigm during TAVI. So the first question is why? Why are we doing LB pacing? And to answer this question and many other questions of TAVI field, we have to go and see the TAVI revolution. So this is a slide that you will see plenty of time. You will know what it is. It's Dr. Reguiero with the first patient 20 years ago. And this is how it started. But now, there has been a huge increase in the number of patients that are being treated with TAVI. In the US, actually, the TAVI is the selected treatment for patients over 65-year-old. And in Europe, it's the same. So this increase in the number of patients has been backed by evidence, and we have now evidence that support this treatment, and is class 1 treatment for patients with severe aortic stenosis with different backgrounds. So the answer for the question goes into, and it goes very similar to what Dr. Harvey said, is adopting tools and techniques that can increase the safety and efficacy and minimize interventions. So during this period of time, we have all the time different questions, and sometimes you have questions and you try to prove it. And sometimes the ideas are good, sometimes are not. So for example, 2011, someone comes up with an idea of use adenosine to do an asystole to implant the valve. They prove this idea, this doesn't work, so they move on. But there are some ideas that actually stand up. So this idea of the LV pacing is not a new idea. The first report was done in 2013 with TAVI, but actually it's a bit, the idea comes back of 2009. This is the same concept, but without TAVI, for balloon valvuloplasty. And this is based on a very old idea, actually, for pacing the patient with a coronary wire. And everything is the same concept. You are trying to minimize interventions to do the procedure more safely. So we take this idea, we move, we check it, and if it's okay, we adopt the idea, trying to minimize the interventions and improve the safety and efficacy of the procedure. Now we have evidence of LV pacing during TAVI. There are plenty of registries from Europe. So this is the first one that was published in 2016. 3 French centers, 125 patients, all of them with significant reduction of the pressure, 1 valve embolization, and 10% of patients who require crossover to implant a pacemaker during the procedure. Only 1 patient with tamponade that was 8 hours, diagnosed 8 hours after the procedure. Another study from Brighton, the UK, 208 patients, also 100% significant reduction of the pressure, 0 patients with valve embolization, and 4% of patients with crossover to right ventricular pacing. So in this study, it's 208 patients, so that's quite a number. But as you can see here, only 8 patients with SAPIEN. So there is a small registry, only 25 patients from Spain, but the point here is that all of these patients were treated with SAPIEN valve, and the results are the same. 100% of significant reduction of the pressure, 0% of valve embolization, no patients with cardiac tamponade, and 4% of crossover to right ventricular pacing. And there are more. We have the study from Oxford, we have from Birmingham in the UK, we also have data from Poland, and we have the data from the Netherlands, from the Erasmus Rotterdam Center. But we also have data from randomized clinical trials. So we have the EASY-TAVI trial. This is a trial in which the patients were randomized to right ventricular pacing versus left ventricular stimulation, 300 patients. And as you can see here, the authors demonstrated that LV stimulation can reduce procedure duration, fluoroscopy time, and cost of the procedure. And you can do that without increasing the adverse events. So as you can see here, 0% of patients with cardiac tamponade due to temporary pacing lead, because you don't have one. So good results. But actually, you can go further, and now we have this guide wire, because all the other studies were done using a Safari or different wires. But now, as you know, we have the SavvyWire. This is a pre-shaped, dedicated TAVI wire that has pacing capabilities. So it's a wire that is isolated very nicely with an orange plastic. So you can isolate the wire, and you have two spots here at the back end of the wire and at the middle of the wire to connect the pacing electrodes. And also, you have a pre-shaped wire to do the TAVI, but this pre-shaped curve is not isolated, so you can ensure that the pacing is correct. The feasibility study was published last year by Dr. Rodez and Ibrahim, 20 patients in Canada. They demonstrated the feasibility of this wire. And now we have the SAFE TAVI trial. This is a trial that had the objective to evaluate the safety and efficacy of this wire using different platforms. The study was conducted in 8 European centers last year, 121 patients. And we're going to present the results of this trial later on at 10 a.m. So if you want to show up, we'll show the results there. But also we have a simultaneous publication in JACC Cardiovascular Intervention. So the abstract and the central figure of the image is available online. Okay, now I'm going to show a few tips and tricks to use the SavvyWire to pace the LV. For the sake of time, it's not going to be very detailed, but those are very important steps to ensure the safety of the procedure. First of all, you need to have all the equipment prepared before putting the wire inside the ventricle, because sometimes when you go with the Safari, actually just going in with the Safari and the patient presents with an AV block. So if you don't have anything prepared, you have to run. So just before putting the wire inside the ventricle, you need to have the grounding, the needle or whatever you're using, all the cables. You can see the SavvyWire here, the monitor, the pacing, everything ready in case that the patient goes with an AV block, so you can respond very quickly. The main advantage of this wire is that it's isolated, so you don't have to put any catheter or anything. So you just put the wire and you can immediately pace the patient, so it's very, very safe. Once you go with the wire, it's also important to ensure that the wire is free, it's not untangled, and that it's well opposed into the wall of the ventricle, because with this way you can ensure that the pacing is going to be correct. So as you can see here, you can see that the wire is not in the mitral apparatus, and it's going very, very nicely into the apex of the left ventricle. Once you are happy with the position, if you are not happy, you just remove the wire and use a pigtail or whatever to be sure that the wire is okay. Then you connect the electrodes, and there are plenty of different ways to do this. One, I actually haven't heard about that one, and I will use it. It's a really nice one, because the standard way is to put a needle, and you are always afraid of having a needle and having a bit of bleeding and going to press the groin, and then you'll have an issue there. But actually, most of the people are doing that. If you don't want to have a needle, another option would be to put directly the alligator into the skin of the patient, and you can do that in the same axis of the TAVI. I mean, here the axis is a bit big, just to put the alligator, but that's another option. There are two more options. One is to use an electrocautery plate to isolate or to ground the wire. And recently, there has been a publication, a report, to connect a wire inside the pigtail. So the pigtail is touching the aorta, and you can connect the grounding to the wire inside the pigtail. The problem there is that you'll have to put a 2E valve to inject through the pigtail. So it's a bit more, I mean, you can do whatever you want, but you have to ensure that the pacing is correct. So before implanting the valve, you go on and put the pacemaker setup. Usually, it depends the heart rate if you are implanting a self-expanding or balloon expandable valve, but you go in between 180 or 200. The output, we recommend to go to the highest output, but if you want to measure the threshold, then at the moment that the patient lost capture, for example, it's 5, then you'll have to double this value to be sure. But it's safer actually to go to 20 or 25, depending on the pacemaker capacities. And also, you need to do asynchronous pacing. So before implanting the valve, you have to do a pacing test So here you can see that we are ready to implant the valve. We haven't crossed the valve, but still we can do the pacing test. And you're looking at the live breath pressure, which is in the pigtail, and the pressure inside the ventricle. And you can see that there is a nice pressure drop with the pacing test, that the pacing test is stable, and you can see here that the pressure drops below 50. So if you're happy with that, then you can move on to do the valve implant. And two very important things here. As you can see here, my hand is holding the wire, because one of the most important things during this time of procedure is to hold the wire steady here, because sometimes when you implant the valve, the wire can move a little bit. So you have to put the hand on the wire and ensure that the wire is placed properly. And the other main advantage of this wire is that you can actually see the pressure inside the ventricle while you are doing pacing. So the red line is the pigtail, but you can see here the white line inside the ventricle. The pressure is below 50, so you can deploy the valve very, very safely. So I would say to conclude that LV pacing is not changing the pacing paradigm. Actually, LV pacing is adopting the TAVI paradigm. So we need to minimize intervention and increase patient safety and security. Thank you very much.
That was an excellent presentation. You showed a couple things there that really were kind of generating thoughts. One, I think the data you showed looking at the U.S. population with I think Harry Dowerman presented that, and it was pretty shocking to see that that you know the guidelines say 65% or 65 or higher, but I have yet to meet a patient who's read the guidelines. Some of my colleagues as well, and so the fact is that that creep is there because we believe in it, and the patients want it, and even our surgeons agree with it, and so it just again reiterates the fact of how important it is that good enough isn't good enough, right? So.